welcome to our first breakout session of the day. This session will discuss cardiomyopathy in adults and with Duchenne muscular dystrophy and adults with Becker muscular dystrophy, There will be time at the end for questions. We would like to welcome our speaker, Dr. Kamdar. Dr. Kamdar is an assistant professor of medicine in the cardiovascular division of the Department of Medicine at the University of Minnesota. She received her MD from the University of Minnesota Medical School, and then she completed her training in internal medicine and cardiovascular disease at the University of Minnesota through the Physician Scientist Training Pathway, in which she pursued a PhD in integrative biology and physiology. She completed her advanced heart failure, heart transplant, and mechanical circulatory support fellowship at the Cleveland Clinic. Her clinical and research interests focus on cardiomyopathy associated with neuromuscular disorders such as muscular dystrophies and clinical and translational research in mechanical circulatory support. Dr. Kamdar, we will now turn the time over to you. And like I said, at the end, we will have Q&A. So when Dr. Kamdar is finished, we'll take some questions.
Well, Jessica, thank you so much for that kind introduction. Well, I just wanted to say it's such a pleasure to be here and really an honor to be able to give this talk today. One of the things that, as I've gone through my training and other things where I, got very interested in neuromuscular disorders. And I think when I was in training for cardiology, everyone was, "You're a cardiologist, are you in the right specialty?" And so, but one of the things that I enjoyed most is meeting patients and their families, patients living with neuromuscular disorders, and just the way that the grassroots efforts that you're all here on a Saturday morning to learn more, and this passion for learning and trying to advance the care. That's something that it's really an honor to be here and talk to you about that, because this is what advances the care for all patients. And so, one of how am I kind of involved with the MDA is through the neuromuscular cardiomyopathy program here at the University of Minnesota, which I'll talk to you a little bit about going forward. But all of my research and my clinical efforts are really focused on neuromuscular disorders and the involvement in the heart. And so I'm going to talk to you today a little bit about getting to the heart of dystrophic cardiomyopathy and understanding how we can advance the care. And so, one of the things that often come up is patients, when they're told that they need to see a cardiologist, it's often a sense of dread. There's something wrong with my heart. And these are normal things to have. But the message I want to share today is one of hope, that as a neuromuscular community, that there are so many things that we can do to advance the care, not only for the skeletal muscle disorder, but also for the cardiovascular impact, and emphasize the research and the other aspects that are being done to improve care. And I'll talk a little bit about the involvement in dystrophic cardiomyopathy. So, as a group, you're very familiar for individuals and families who are living with neuromuscular disorders, especially dystrophinopathies, of the heart involvement. So here in my talk, I'm going to cover all of the dystrophinopathies, which include Duchenne, Becker, and then also dystrophinopathy carriers. And so just briefly talking about the pathophysiology, so we know that this is a result of changes in the dystrophin gene, resulting in the full-length dystrophin protein not being expressed. And the dystrophin protein is really a big protein in the heart and in the skeletal muscle. So that's where the two major spots, it's expressed, and in addition, also in the brain, but a slightly different form of the protein. So what exactly does dystrophin do? It's basically a shock absorber in the heart. And dystrophin helps connect the outside of the heart cell to the inside of the heart cell, which does the contraction. And so it helps spread out all of the stress that individual heart cells see. And so it plays a critical role in keeping the heart muscle cells healthy and moving. But in the dystrophinopathies, so patients living with dystrophinopathies don't have the full-length protein, which doesn't allow it to bind to the outside of the cell and the inside of the cell. So those cells are under more stress because they have lost their shock absorber. And so when the dystrophin protein, the shock absorber, is not there, some of the changes that can occur are heart muscle scar tissue or fibrosis, and that can then progress towards changes in the heart muscle itself, which can lead to heart failure, and then changes in different rhythms, which I'm going to go through in a little bit more. So overall, DMD and the other dystrophinopathies cause not only muscle weakness, but also skeletal and cardiac. And as patients are now living longer, which is a wonderful thing that over time the neuromuscular community has come together, and with advances in respiratory care by our pulmonology colleagues and by our spinal stabilization, especially in Duchenne muscular dystrophy by our orthopedic colleagues, there's been an advance in the care, and patients are now living longer. Yet, it is also my hope that that in the next 20 years, that we will look at this and the survival will continue to improve. But one of the things that we've identified as patients with dystrophinopathies are living longer is that there is now more heart failure or cardiomyopathy that's being identified. And so, again, I just want to emphasize neuromuscular disorders also involve the heart. So this is a list of different neuromuscular disorders and heart involvement. And I just want to emphasize here, this is where this is really critical, that patients who have Duchenne, Becker muscular dystrophy, and then dystrophinopathy carriers, which include both DMD and BMD carriers, have, due to loss of dystrophin, have heart involvement. And this heart involvement can be variable. So not everyone has the same heart involvement, and that's what, because of the large number of changes in the dystrophin gene, that's where we don't know exactly why one mutation causes one change versus another. So one of the aspects that we know about heart muscle in Duchenne and Becker muscular dystrophy is that there's scar tissue that forms. So initially, the only way that we could identify if there was scar tissue in the heart was either getting a biopsy of the heart muscle itself, which is invasive. So as a transplant cardiologist, I do this for my transplant patients, but it's not easy to do, go in and take a piece of the heart. Or at the time of autopsy, it was identified that there was scar tissue in the heart. And so in this picture on the left, this is a piece of the heart muscle from a patient with Duchenne muscular dystrophy. And you can see here normal heart muscle tissue that's in pink. The tissue that's in blue that you see here, what's the staining, that's actually scar tissue that's infiltrated throughout the heart. And with the loss of heart muscle cells, there's replacement by fat, which is not dissimilar to what happens in the skeletal muscle. But now we don't need to wait to find out if there's scar tissue until we biopsy patients or we get tissue at later stages. However, we can use cardiac MRI, which allows us to actually detect if there's scar tissue in the heart. So in this picture on the right is a picture from an image from a patient with Duchenne muscular dystrophy. And so what I would like to highlight here is that on the cardiac MRI, normal heart tissue is in black, and this is the left ventricle here and the right ventricle. So what we see is that this areas where they're white is quite extensive. It's almost 50% of the heart in this patient with Duchenne muscular dystrophy. And in this patient, the heart muscle function was slightly reduced. But really, the key of being able to identify what is causing some of these changes is part of understanding how heart tissue fibrosis occurs. And again, this goes back to the shock absorber. Now, when cells don't have that shock absorber, over time, the heart muscle cells die, and they are replaced by scar tissue. Just like if we get a cut on our skin, the same thing happens in the heart. And scar tissue occurs in heart for a variety of reasons. It can be from a heart attack, but it can also be due to genetic cardiomyopathies. So this is actually quite common in other gene mutations that cause heart dysfunction, but it's especially prominent in patients who have Duchenne and Becker muscular dystrophy. So how is cardiomyopathy and heart involvement identified in Duchenne muscular dystrophy? So there's a progression. And Dr. Karachensky spoke about early diagnosis, and that's what's really key here, is individuals living with Duchenne and Becker muscular dystrophy, their heart is there's no scar initially, the function is normal, and then over time, And again, the timeline by which these different changes occur is variable depending on the individual patient and the changes in the dystrophin gene. But one of the first signs we see before there's any change in the heart function is actually a little bit of scar tissue. And that scar tissue, predominantly in patients with dystrophinopathies, occurs in the back wall of the heart. There's still ongoing research as to why specifically that part of the heart is affected by neuromuscular cardiomyopathies. But when we see that on an MRI, we know that's typically associated with neuromuscular disorders, such as Becker and Duchenne muscular dystrophy. Over time, that scar tissue is replacing normal heart muscle. And with that, what happens is that now the heart muscle isn't able to provide the same level of contraction. It creates stress for the heart. Over time, the heart muscle gets weaker and then the heart muscle can dilate. So the heart is more of a football type of shape, and over time, it can become more of a basketball. And so that leads to, there's progressive development of fibrosis or scar tissue, and then this leads to more fibrosis and then can lead to end-stage heart failure. But again, just to emphasize, again, for HOPE, we can address this much earlier before we're reaching these end stages. Previously, many patients were only seen when they're in the later stages of the cardiomyopathy. And so if you look at the data from previous decades, those don't necessarily reflect the same practices as now. Dr. King also emphasized in his talk earlier about the rapid changes in the treatment and understanding of these disorders, and that really is part of what we have hope for. So when there's scar tissue in the heart, it changes the connection of the cells, which also changes the electrical activity. So the heart, like muscle cell, is electrically active. And so we can actually identify changes in the heart muscle and fibrosis by looking at an electrocardiogram or an ECG. And so this looks like chicken scratch, I know, but when individuals like myself who are cardiologists look at this, we can look at the changes, and this reflects changes in the heart muscle and changes in the electrical system in patients with Duchenne and Becker muscular dystrophy. So there's kind of two aspects, as I highlighted before. One is changes in the heart muscle itself, and then the second aspects are really changes in the electrical system of the heart. And arrhythmias are common in neuromuscular disorders like Duchenne and Becker muscular dystrophy. And there are various dysrhythmias that involve the top chambers of the heart, which are the atria, and the bottom chambers of the heart, which are the ventricles. And then there's a risk of abnormal heartbeats. But many patients don't sense these, and this is part of what I'm going to talk about soon. And then symptoms that can also include palpitations, skip beats, missed beats, racing heart, and feeling like you might pass out. And if you have these feelings, you need to let your neurologist or cardiologist know. If you pass out or your family member passes out, know that this is a medical emergency and that they should seek care in the emergency room to understand why this has happened. So these are some, again, a little bit more chicken scratch on a Saturday morning, but here's what normal sinus rhythm. So this is the typical rhythm, what we consider normal. This is atrial fibrillation. This is what happens with the top chambers of the heart where the electrical signal is not distributed equally and the heart basically twitches on the top chambers. This is, there are issues with atrial fibrillation. They can occur in patients with dystrophinopathies. This is less of a serious type of dysrhythmia, but it can, because when the top chambers of the heart aren't functioning normally, it can increase the risk of developing blood clots. So it is something that's important to be able to identify. One of the aspects that we're more concerned about is the development of what's called ventricular arrhythmias. Again, that's from the bottom chambers of the heart. And so these are more scary. Because when the bottom chambers of the heart aren't functioning, it can't effectively pump blood to the rest of the body. Patients often pass out or have fainting episodes if they have these. And it's really important to be able to identify this because there is treatment to reduce the risk and reduce the risk of dying suddenly related to these types of dysrhythmias. So one of the aspects that's really important is understanding how do we care for patients who have dystrophinopathies and who are living with dystrophinopathies. And one of the things you can see on my slide is that these guidelines were actually published in 2017. This is the American Heart Association. So this is one of the largest cardiovascular organizations in the United States. And this is in 2017 was the first time that the AHA put together guidelines for the care of patients with neuromuscular disorders that include dystrophinopathies. And so I think that highlights a change in the paradigm where individuals, including cardiologists, are focusing on the care of patients with neuromuscular disorders. One of the aspects I'd like to highlight that both Dr. Kirachensky and Dr. King also discussed is the proactive care of patients with neuromuscular disorders, including dystrophinopathies. So this really includes early screening and early diagnosis of cardiovascular involvement in dystrophinopathies. The screening should occur at the time of diagnosis. And again, I'm an adult cardiologist, and you'll hear from Dr. Rogers later this afternoon a little bit about the care of dystrophinopathy patients from a pediatric side. So I'm not going to cover that part of the guidelines in my talk today, but I'll talk a little bit about the other aspects of the care. And I'm just going to summarize some of these changes. So patients who have dystrophinopathies, as I showed you earlier, can have fibrosis and don't often have symptoms. And so if they have changes in the heart, patients should be screened at least once a year. And again, these are the national guidelines. And if there are changes in the heart muscle or abnormal rhythms, these patients should actually be seen sooner. And then so that is an important aspect. So being able to identify patients who have heart muscle disorders, heart muscle involvement, and being able to see them and treat them in an appropriate time. So how do we look for cardiovascular involvement in patients with dystrophinopathies? Many of you in this room, may have undergone this or seen your family members have some of these, but cardiac imaging is one of the first aspects. So this can include echocardiography, so this is when a surface echo or ultrasound is done of the heart that can tell us about the heart muscle. And then the cardiac MRI, that is a specific aspect that can really help us to understand cardiovascular involvement in patients with dystrophinopathies. So the echocardiogram tells us important aspects about the heart function. But as I told you earlier, that one of the earliest signs of heart muscle involvement in dystrophinopathies is actually the scar tissue that forms. So the cardiac MRI gives the same information as the echo with regards to the heart function. So is the heart beating normally? Is there change in the thickness of the walls of the heart? But a real advantage of the cardiac MRI are twofold. One is that with contrast, so that's called gadolinium, it's different than other contrast, is given an injection during the cardiac MRI. This gadolinium specifically goes into areas where there's scar tissue, and that this can actually identify and show, as I showed the MRI earlier, where there's scar tissue. The second aspect is often in patients with dystrophinopathies, sometimes the echocardiogram, especially if they're wheelchair users, is not the easiest. And so sometimes we don't get great images. And so cardiac MRI can give us better images and better understanding of the heart. So in our clinic, which I'll also go over the protocol here, is using cardiac MRI because really it's the early identification of the fibrosis that we can treat. And then ambulatory electrographic monitoring, which is things like Holter monitors or Zio patches. I talked a little bit about changes in the heart rhythm in patients with dystrophinopathies. These are often not felt by patients, so some people have symptoms like palpitations or dizziness or lightheadedness, but often many patients don't have a lot of symptoms. But the little monitors that you wear, the little electrical patches, actually look at heart rhythms over time and can tell us if there are abnormal rhythms that are happening that patients don't feel or detect, because those can also be appropriately treated. And then their electrocardiogram, as I showed you earlier, that should happen at least once a year in all patients. So, and then I've talked a lot about patients who have Duchenne muscular dystrophy, but what about the women who are carriers of the gene? So we're increasingly identifying that there's heart involvement in women who are carriers of Duchenne or Becker muscular dystrophy. So this is one of the earliest guidelines that have actually been published about what should be done for carriers. And so this is very important. There's variable heart involvement in carriers. Some have none and some have significant heart involvement. But the current guidelines recommend that carriers should undergo cardiac evaluation, which I just had outlined on the previous slides, starting in their 20s to 30s. These are the same types of screening exams that are done in patients who have Duchenne or Becker muscular dystrophy. The current recommendations are actually for follow-up every 3 to 5 years. Again, I think that based on some of the work that we're doing in our clinic, we actually see carriers back more frequently. And so what are other important aspects to consider for the heart care, not only in carriers but also in other patients with dystrophinopathies, is that there should be cardiac evaluation prior to any surgery that requires anesthesia, because anesthesia can affect the heart and blood vessels in terms of the hemodynamics or how the heart responds to anesthesia. So that's really an important aspect. And for patients who are at an increased risk for heart issues, that include patients who have changes in their heart muscle or have previously been diagnosed with arrhythmias, it's very important that the anesthesiologist is aware of the diagnosis and then is also appropriately monitoring the heart muscle and heart rhythm during the surgery, and that the center has the resources, meaning neuromuscular neurologists, cardiologists, and intensive care units that can appropriately care for patients. So to summarize the guidelines, and this figure just kind of nicely puts everything together. So important is diagnosis of cardiovascular involvement. So those are seeing your cardiologist, getting the testing done that includes echocardiography or cardiac MRI, ECGs, as well as ambulatory telemetry monitoring. So that's the first aspect. And then this is kind of divided up. So for this concerns more of the pediatric patients, but for patients at all stages, they should continue to have ongoing follow-up with a cardiologist. And then again, in special circumstances like surgery, should also see a cardiologist for optimization. And then here we also have the assessment of carriers, which is in the guidelines now, and then for patients who have changes or who are symptomatic, that there should be an increase in frequency of seeing their cardiologist, and then initiation of pharmacologic therapy or medications. So here, going back to what we know about dystrophic cardiomyopathy, so what happens when patients come and they have already changes in their heart muscle? So again, I'd like to emphasize the hope that we have for these patients, that even if there's heart involvement, even if the ejection fraction is reduced, patients can go on to feel well and do well, as long as they're addressing the changes that have occurred in the heart. And this is something that your cardiologist can help you with. So as a heart failure cardiologist, I see this quite frequently in patients who have other types of heart failure, meaning heart muscle dysfunction, and that there's changes in the heart muscle. And with a regimen of 4 drugs that address the changes that occur in heart failure, we can actually go from changes, meaning heart dysfunction, to heart function, and actually return this back to normal. We don't have in patients with dystrophinopathies, we don't know the exact percentage of patients that can go from the later stages of heart dysfunction to the other earlier stages, but based on my experience in seeing patients who have dystrophinopathies who've been able to aggressively start on medications, we have seen an improvement in heart function, a reduction in arrhythmias, and stop or at least slowing down the progression of scar tissue. And so this is additional work that our group is doing in addition to other neuromuscular cardiomyopathy clinics to understand how we should treat patients with dystrophic cardiomyopathy. And so what are some of these therapies that we can use in patients who have dystrophinopathies? So the current heart failure therapies that are approved to improve heart function, so these are FDA approved, are 4 categories. So we call this the 4 pillars, and I'll show you a slide about this in a moment, is angiotensin receptor blockers and ARB blockers. So this is work that was done early on in Duchenne and Becker muscular dystrophy patients that show patients who are started on these medications earlier, it can actually slow the progression over time. So these are really key. Beta blockers, these are drugs that actually target the receptors on the heart that help slow down and prevent abnormal rhythms. Mineralocorticoid receptors, these are medications like eplerenone and spironolactone, which have also been tested in patients with dystrophinopathies and have shown to be a benefit. And then the last category, which is the most recent in the last several years, is SGLT2 inhibitors. So this is a drug that's been developed for diabetes, but has very significant impact on heart muscle and can actually, again, with the 4-drug regimen, can actually help move patients towards normal function. And so there are actually, so this is, again, for overall patients with heart failure, these are the therapies that we have. And so these are the trials in which they've undertaken in all comers of heart failure. So we don't have as much specific data with regards to patients with dystrophinopathies. However, you can see that there's a significant change. We can increase survival, and we can decrease abnormal changes in the heart with these medications. And then this just really emphasizes, again here, these are the 4 pillars of heart failure therapy that include ACE inhibitors, beta blockers, SGLT2 inhibitors, and mineralocorticoid receptors. And this is what, as a heart failure cardiologist, we're used to starting these medications and seeing improvement in patients. And I'd say for all comers of heart failure, about 2/3 of patients will actually improve their heart function or completely normalize the heart function. And I actually have seen some dystrophinopathy patients who we've been able to almost nearly normalize their heart function with medication. So it just emphasizes the early care and diagnosis of heart involvement in patients and aggressive cardiovascular care for patients with dystrophinopathies. And so what are some of the challenges of the medical management of patients with dystrophic cardiomyopathy? So many of the patients, so the trials on the slide I showed you previously, many patients who have dystrophic heart failure or dystrophinopathies were not included in these trials. There are smaller trials of patients with dystrophinopathies. However, they're not of the same type as we have for the other larger group of patients. There's also a lot of heterogeneity in dystrophinopathies with different mutations, different levels of heart involvement. Some patients don't tolerate a lot of medication because of low blood pressure. And one of the other challenges is especially for patients who have less ambulation or eventually are users of wheelchairs, that because they're not exerting themselves as much, some of the classical signs for heart failure or heart involvement are not often evident. So, typically what we discuss in heart failure is, is your ability to exercise reduced? Are you getting short of breath when you walk up 2 flights of stairs or when you walk a certain distance? Often, those are not the signs of heart failure that we see in patients who have dystrophinopathies. And so that's part of also understanding and getting that symptoms in patients who have dystrophinopathies may be different in symptoms with other types of heart failure. So other things to look for are swelling in your legs, swelling in your abdomen, not being able to eat as much, getting full really early, feeling really tired, more so even if you're getting a good night's sleep, you wake up and you're tired. And those can also be interrelated with the skeletal muscle dysfunction, but those are other signs in patients who have dystrophinopathies. And so part of what I also wanted to talk about is a little bit of the research that we're doing, both clinically and from a more cellular standpoint. So one of the things that we looked at is, so our patients, I talked about these really impressive treatment therapies, the 4-drug regimen that help improve heart failure. But are patients with dystrophinopathies being treated with these medications? So we looked at beta blockers, which have been in the guidelines for heart failure for a long period of time. And there's specific heart failure beta blockers, which I'm not going to go into here. But looking at the MDA US Neuromuscular Registry, we looked at almost 700 patients living with Duchenne muscular dystrophy. And if you look at this, we looked at the number of patients that were on beta blockers. As you can see, 12% of patients with Duchenne muscular dystrophy were on beta blockers based on a registry that includes 18 large neuromuscular centers. And then if you further look at whether those patients were on heart failure-related beta blockers, that decreases to 9%. So this is a clinical gap that we've identified with research in trying to understand what the barriers are to starting medication or starting these therapies in patients with dystrophinopathies. I'm only going to briefly touch about device therapy and dystrophinopathies. So we talked about abnormal rhythms. When patients' ejection fractions or heart function is below 35%, we know based on other heart failure states that increases the risk of abnormal rhythms that come from the bottom chamber of the heart, like ventricular arrhythmias. And when patients' ejection fractions below 35%, despite medical therapy, we often recommend seeing an electrophysiologist, a heart rhythm doctor, to be able to consider things like pacemakers or defibrillators, which are effectively an insurance policy that if there's an abnormal rhythm, it can provide a shock to restore the function and electrical system of the heart. And if there's abnormal rhythms, we refer patients to, again, also our electrophysiologists in case there are additional therapies that are needed. So again, talking about the clinical gap, this is, again, an analysis of the MDA U.S. Neuromuscular Registry. So we looked at our patients who have diagnoses of neuromuscular disorders. Are they seeing a cardiologist? And so what we identified is that, especially as an adult cardiologist, only 3% of patients are being seen throughout the country. And this is one of the U.S. Neuromuscular Registry and now the MOVER Registry are the largest registries of patients with neuromuscular disorders. So this is really a gap in the care for patients and understanding what the barriers are to care. So from this gap in the care, which we identified from research, is that at the University of Minnesota, we started a adult neuromuscular cardiomyopathy clinic. So this was started in 2014, and both myself and Dr. Gary are cardiologists that see patients in the adult side. In 2017, when I started as faculty, I also started a dystrophinopathy carrier clinic. This is multidisciplinary, so we get to work with individuals like Dr. Karachunsky, Dr. Kang, and Dr. Manasakis, who you may have met earlier, as well as genetic counselors, our pediatric cardiologist, Dr. Rogers, who you'll meet later this afternoon. And this is very interdisciplinary. We see all patients with neuromuscular disorders to screen for cardiac involvement, and then also some of the other advanced treatment that heart failure cardiologists like myself and Dr. Gary can also bring, and we also have a registry to look at these patients. So our protocol is that all patients are seen. Patients, we get an MRI, ECG, and ambulatory telemetry, laboratory testing, and then we have a regimen to start therapies, including ACE inhibitors, angiotensin receptor blockers, as well as spironolactone or MRAs. And if the ejection fraction is reduced, meaning the heart function is reduced, we start neurohormonal therapies sooner and increase this. We have quite aggressive in increasing medications in patients. So if you look at our patient population, looked at the number of patients who are on medications, it is much higher than what you saw in some of the previous slides. We typically see patients at least once a year, and this is really important. And the reason that we do our clinic along with our neuromuscular colleagues is so that it makes it easier. So when patients are coming to see their neuromuscular neurologist, they can also see us. And if there's heart involvement, we may see you more frequently. And then I'm just going to, as we're getting close on time, I'm just going to briefly talk about, as an advanced heart failure and transplant cardiologist, an area that I'm really passionate about is advanced heart failure therapies in patients with neuromuscular disorders. So we know that patients with dystrophinopathies can progress to advanced heart failure, meaning that the medications are no longer effective, they're not getting good blood flow from their heart enough to sustain their body functions. And in this case, in other patients, they undergo aspects like heart transplantation or heart pumps. But often, patients with neuromuscular disorders have been thought not to be candidates for aspects like heart pumps and heart disorders. So some of the research that we've done looking at a registry of patients with transplant is look at patients who've undergone transplant who have a neuromuscular cardiomyopathy. And what we can see here is this dashed line represents patients who underwent transplant with neuromuscular cardiomyopathy, and this is about 100 patients in this study, and then other patients with neuromuscular. And what we saw is that there's no significant difference in survival between these, again, highly selected patients who underwent transplant with neuromuscular disorders. And this is something that's really important because this is data that I've also used to convince our cardiac surgeons to have patients who have neuromuscular disorders undergo heart transplant or LVADs or heart pumps in our program. So we've now transplanted or implanted heart pumps in close to 15 patients with neuromuscular disorders, which is one of the largest advanced heart failure populations with neuromuscular disorders in the country. And then, so again, and I appreciate the generous funding from the MDA. So we're actually now, these questions, should patients with neuromuscular disorders be transplanted or have heart pumps? So now this has actually led to a multi-center study. So we have 5 MDA sites and then another 10 non-clinical MDA, or non-MDA sites that do advanced heart failure. And so we have, this is a distribution all over the country. We're actually looking at real life data. So the registry gives us some information, but we can actually look at the data that's really relevant to advanced heart failure care in these patients. And I'm looking forward to sharing some of these results as we get more data in setting the guidelines of what heart failure care should be for DMD cardiomyopathy patients. Additional, aspects that we're also looking at that's really important is the cardiac involvement and cardiopulmonary reserve in women who are carriers of dystrophinopathies. And this is generous funding by the Marzoff Foundation. And then we're looking at stress testing as well as cardiac MRI and ECG to understand how heart involvement occurs in dystrophic carriers. And then one of the things I'm also excited to share, this is still far from clinical aspects, but one aspect that my lab does is using patients' skin cells to make heart muscle cells from patients who have Duchenne muscular dystrophy. So we can develop stem cells from patients. Dr. King talked a little bit about human iPS cells, which they're using in trials, but we can actually use those stem cells to we give a cocktail of different drugs to make them into heart cells. But one of the things that my lab is now doing is actually printing 3D models of hearts using patient stem cells. So this is just an example here of these little hearts that we're creating, where we can take the patient stem cells in a cocktail of medications plus some other aspects and actually print these little hearts based off MRIs from patients. And so this actually allows us to really study DMD cardiomyopathy. And so my work in this is mostly in Duchenne muscular dystrophy, but you can see here, these are the normal control cells. They express dystrophin. Our dystrophic cells our dystrophic heart muscle tissue does not express dystrophin, which is a reflection of the pathophysiology in patients. But more importantly, we can actually measure abnormal rhythms in these mini hearts. And we can see that the control cells don't have abnormal rhythms, but even even at baseline, without any therapies, these dystrophic hearts have some abnormal rhythms. And that if we stress the heart, we can actually worsen the abnormal rhythm. So this just shows no treatment and then adding a drug that actually induces heart failure increases abnormal rhythms. And so those are the aspects that, as a neuromuscular community, can advance the care for patients with neuromuscular disorders, including dystrophinopathy, heart failure. So cardiac involvement, in conclusion, includes both cardiomyopathy, heart muscle weakness, as well as arrhythmias. Early cardiovascular screening is really key in all patients with dystrophinopathies. A regular cardiology care is necessary and helps to prevent further progression. So starting medications, if there is a problem, your cardiologist can help you try to address that. And then there should be appropriate heart failure care in that we should consider the dystrophinopathy abnormal rhythms. And then I just wanted to acknowledge, the MD Center as well as the Neuromuscular Cardiomyopathy Program and work done by my lab. And thank you, and be glad to take some questions.